Good morning. Thank you for the introduction and for the invitation. Indeed, what will happen to patients after post-anoxic coma? For this intervention, I have no conflict of interest to report. There has been a lot of change that happened in tandem with the introduction of therapeutic hypothermia or targeted temperature management, as well as the care of what is called post-resuscitation disease. And on this slide here, I've summarized the tools that are currently available, starting from the fact that the neurological clinical examination is still the first starting point. Then I'll mostly talk about electrophysiological examination, a bit about biomarkers, and for this presentation, given that it's slightly hands-on, I'm not going to talk about the role of MRIs that may play a role to assess the long-term outcomes in particular, but in the acute phase, in the first few hours and days, it's not yet available everywhere. It doesn't really have a clear role to play in terms of outcome and prognosis in this context. Why talk about outcome evaluation? As I said at the beginning, we used not to really deal with cardiac arrests in the 90s. Then there was TTM, improving the outcomes for these patients. And then we realized that the guidelines that were issued in 2006, especially by the American Academy of Neurology, and that was entirely based on neurological clinical examinations, especially motor response, the Glasgow score, and brainstem reflex with pupillary and corneal reflexes were no longer so reliable in the studies of the years 2000, during which TTM was used gradually. Here I've included 3 studies. 2008 was important because it said that you should wait up to 6 days to recover motor response in patients with TTM. Here TTM with sedation, gradually removing sedatives in hypothermia, and there was this false positive rate to predict a poor outcome. What's ideal is to have 0%, 1 minus specificity, 100% specificity equals 1. 1 minus 1 is 0, so the best predictor is a false positive rate to predict a poor outcome of 0%, and it reaches 24%. And even for brainstem reflexes, even if they remain good, the false positive rate was inadequate, and so it's not necessarily good on its own. In the guidelines, as it says, an additional tool is suggested, EEG. And what was said is that you should wait for at least 3 days or more. 3 days or more in our constraints may sometimes be a long time to remain uncertain. So electroencephalogram, it's a review of how you can use EEG. There's the EEG that you see, that you record, with grades of gradual slowdown. And you can score the severity. For instance, the presence of burst suppression, spontaneous burst suppression, as I'll show you, a very slow line, or the presence of epileptiform activity or epileptic seizures. And there's a more dynamic aspect that I'll talk about, testing responsiveness of the EEG, of the baseline EEG curve to external stimuli, as I'll explain. Here, this is what you can see in a patient who, at first sight, will have a good outcome. You can see while on sedation and TTM in the first 24 hours, they have a continuous line associated with the good outcome. Conversely, if you have a discontinuous background, a flat line with bursts or a pattern like spontaneous burst suppression, similar to induced burst suppression with barbiturate-induced coma. In several studies, this is associated with an unfavorable outcome, a patient who's not going to wake up. And then you have everything associated with epileptic seizures, like generalized periodic epileptiform discharges, expressing severe brain hypoxia. There's still a debate. There's a 10 to 30% incidence of epileptic seizures. Where the EEG is important is that you can detect it and assess treatment if seizures happen very early in a patient sedated and cooled down. Very often it's a bad prognosis. If they happen later, if there are other positive EEG signs, then it's worthwhile giving treatment. Here, this is a major sign, EEG reactivity. You have an intermittent EEG. It's not necessarily to have it continuously. And you have this background, and in red, the arrow is pain stimulation or oral stimulation. And the black arrow shows the change in amplitude and frequency of the EEG, as you can see here. This is an EEG where the lines are responsive, and the opposite is that before or after, there's no difference. This is a test that you can do twice. That gives you a very clear signal in terms of prognosis. It was described in 2010 in a population of over 100 patients. And you can see that the presence of an unreactive EEG background was 100% predictive of a bad diagnosis, of bad outcome. And in terms of overall care, it's important that you can get this information very early on. Including EEG already back then in the clinical examination significantly improved the prediction. In other groups in the US, especially the Mayo Clinic, or in Sweden and the Netherlands, the prognostic validity of the EEG was described, and there's one key element. Contrary to evoked potentials that I'll discuss later, and this opened a different view of things, sort of a paradigm shift. People always talk about bad prognosis. What's also interesting and encouraging to know is to know very early on what patients are going to wake up, to invest as much as possible. And in fact, responsiveness, when the EEG is responsive, yeah, it's 70 to 90% predictive of a favorable outcome, CPC 1 or 2. So moderate handicap. This is important information. Evoked potentials may not necessarily give you this information. Evoked potentials, here on the left-hand side, you have the presence of this potential, which is a stimulation of the median nerve N20 with negative deflection, and on the right-hand side this deflection disappears. Several studies. This is the largest study published by a group in the Netherlands, Yannick Hoorn, 391 patients, serial tests, evoked potentials within 48 hours. So they had a clinical examination, NSE levels, and oral sensory potentials during the hypothermia phase and after rewarming. This is also what you do with the EEG while they're still sedated under TTM, and once they are no longer sedated and coming back to normal temperatures. What's really impressive is that During hypothermia and normothermia, it's a bit more variable in hypothermia, but in normothermia, hence the importance of having this test at least twice, both neurological and electrophysiological. All those who had no evoked potentials, and this bilateral absence of evoked potential for the N20 during normothermia, 100% had a bad outcome. And if you look at the false positive rate, here for evoked potentials there was no EEG, but the variability for NSC above 33, which was the famous cutoff, which is no longer recognized. And here neurological examination, pupillary test is quite good. I'll come back to that. This is a summary of all available studies, over 2,000 patients, almost 500 auditive evoked potentials, auditory evoked potentials, and they're very good to predict those who won't wake up. Almost 0% false positive rate. But the flip side is that when you have evoked potentials, in fact, you don't know what to do, contrary to EEG, the EEG responsiveness. And this is where between EEG and evoked potentials, the advantage of EEG is that you can detect seizures. And when seizures happen, which I described here as late seizures, when they happen once the patient is no longer sedated under TTM, once the anti-epileptical intrinsic effects disappear, you have a responsive EEG, you have seizures, you can treat for that, and the patients will recover. That's the difference over evoked potentials. It's a bit easier to have than evoked potentials, I think, and you can quickly see a patient with potential recovery when there is activity, which is not the case with evoked potentials. Biomarkers. Biomarkers. Well, as always, there are only biomarkers. There are severity biomarkers. If you have 15 of lactate on arrival, it's less good than if you've got 5. Another group highlighted procalcitonin. Since we control infections a lot, do not use procalcitonin to control infections, because procalcitonin increases because of ischemia, reperfusion ischemia stress. And a French group showed it, talking about sepsis-like syndrome. It reflects sepsis, so procalcitonin is a marker of bad outcome. For more specifically cerebral markers, there's neuron-specific enolase. There's also S100 beta or GFAP. There are a lot of biomarkers if you read the literature in this area, but none of them is robust, and there shouldn't be one. I may say this is a study we did in Lausanne, but other centers also proved it. I showed you the Dutch team. In people with CPC 1 or 2, the range was between 8 and 51 for NSC. So you can't just go by the value of one single biomarker, even if you have repeated tests. If there are problems in terms of tests or hemolysis, don't just rely on one biomarker. You should mostly rely on the multimodal approach. This is what we do more and more nowadays. What we tested in this study that I conducted with Andrea Rossetti, and I'll take this opportunity to thank him for his huge contribution. He's a neurologist whom we work with, and I hope that it's essential for prognostication to cooperate with the neurology team. First for the EEG, but also for all the rest. And here you can see 134 patients. You can see all the tests done on the left-hand side. Here again, there are 5 patients who arrived and they were perfectly fine. NSC over 33, even if you include CPC 1 and 2, same. When you have zeros, that's really EEG and evoked potentials. Now you take each test and you only have the clinical examination. Not bad, 0.78. And we do a lot of EEG. The absence of EEG response was the strongest if taken in isolation. Where we were the best is the association of clinical examination, electrophysiology, in this case EEG. With EEG, evoked potentials did not provide anything, and NSC. And if you combine the three, the area under the curve is 0.89 for mortality and 0.80 for outcome, combining poor and good outcome. And then we're more or less sure that we can probably stop doing anything if there's the absence of brainstem reflex, no responsive EEG, bilaterally absent N20 on SSEP. Sometimes patients have an EEG that's reactive and NSC at 40. You need to continue. So you need to have various tests. And you can do that early on, and especially if you have a patient with epileptiform discharges, NSC at 40 and an EEG that's responsive, you need to treat. This is major information for the team as well and for patient management. In the following minutes, I wanted to look forward to future perspectives. You hear a lot about tools that may not be so simple to use. I've discussed it, EEG and so on, it's not always available. And if you go back over the clinical examination, I think that the most robust test is pupillary reflex. The problem with this test is that it's in fact dichotomized, present or absent. You need first a good flashlight, and it's not always easy to see pupillary reflex. Patients are sedated on opioids, they're cooled down. It's not always easy. Pupillary light reflex is robust. Maybe we could have a quantitative test. I'm not going to advertise, I'm not getting a cent out of it, but there are two devices that are available, Neurolight from France and Neuroptics from the US, to quantify in percentage the pupillary light reflex, saying that there was 15% motion. Neuroptics also includes an algorithm that gives you a figure. We tested with Neurolight, comparing standard pupillometry with a working torch, pen light, and we compared that to quantitative pupillometry. I didn't give you the reference we published in Critical Care last year. The quantitative PLR was superior to the standard pupillometer, and it was comparable to evoked potentials or EEG in a number of patients. So it's interesting to explore that. And then you can get more sophisticated. Here I wanted to thank the NeuroSeti team, but there's also the biomedical imaging team in Lausanne. They are PhD physicists, and it was interesting to see them arrive the first time in the ICU because they were it wasn't easy for them. And in fact, they set up an algorithm that's based on standard EEG with 19 channels, and they do a topographical analysis. Through headphones, they send monotone sounds, and there's a standard sound and there's a deviating sound. And if the brain works, it can discriminate between the two sounds, see the difference. And so here, since they can see they can pick up the difference in sounds, they can see mismatch negativity. If it works, that's the standard monotone. You could hear the deviation. This is what the patient hears, the patient on TTM. At the same time, there's a recording during and after hypothermia. Here the EEG. And in fact, you have the first recording here. You can see the dots with the colors. The brain cannot really tell the two apart. Tell that there are two sounds. In normothermia, on the right-hand side, the brain can do it. These two are identical, and these two are different. And so there's an improvement in the ability to decode. All patients who have this discriminatory ability, all of them woke up. About 70 patients here. This is an indication on the first 30. So by definition, patients are not aware, they're sedated, and they are cooled down, but something works in the brain. And we could look to the future, those who recover early, and I think that we can go from 70% to something better. And to conclude with something a bit more pragmatic, this is one of the approaches that we recently suggested. So to summarize, I think that neurological examinations are still important. Pupillary light reflexes are something that we should take a deeper look at. Motor response, be careful. Electrophysiology provides a bit more with EEG because you can detect seizures, because it can predict good and bad outcomes or evoked potentials, and with biomarkers there's no silver bullet for biomarkers in isolation, but they can be included in this multimodal approach. Thank you very much. Good